Again, I am Alexa Tinsley. I'm the Director of Programs here at Jett Foundation. We thank you all for joining us today. We're very excited to hear from Dr. Truba today about behavior in carriers. We know that you are excited to hear it as well. I just want to say thank you to Dr. Truba for helping us make this webinar possible, sharing her knowledge and her expertise with us as much as possible, especially on such a unknown and new topic. So if you don't already know, Dr. Truba is currently employed as an attending psychologist at Nationwide Children's Hospital and is primarily responsible for inpatient psychological behavioral healthcare needs of patients managed by complex care, neuromuscular, and/or physical medicine rehab teams. So before we get started, I do just want to mention a few things. If this is your first webinar series, we do these throughout the year. So if you want to see what we have coming up, feel free to look at our website. This webinar is being recorded, so if you have to log off for any reason, it will be in our on our website and on our YouTube for later watching at your convenience. And if you know of anybody that was not able to attend and may have wanted to watch this webinar, you can share the recording with them as well. It will be emailed to all of you after we get it up and it's ready to go. So after the presentation, we will also be answering questions. There is a question box for me, it's the bottom right-hand side. It's changed a little bit, so it's now a little chat box with a question mark in it. We will be trying to get to all of your questions. So if you do have any, please feel free to put them in there. We do try to monitor the chat, but don't always do the best job. We do our best, but we don't always get to all of them. So if you could please put them in that Q&A portion, that would be great. We are also streaming this live to Facebook, and we do try to monitor questions from there as well. Also, if you need any closed captioning or language translation, that is on the bottom of your screen as well. There's a toggle that says CC, and you should be able to get a full transcript in whatever language that you choose. So with that, I will stop talking and I will hand it over to Dr. Truba.
Thank you so much, Alexa. Good afternoon, everybody. I'm Natlie. I'm a pediatric psychologist at Nationwide Children's Hospital in Columbus. I'm not going to lie, this was a bit of a challenging talk to put together just because of the lack of information. So I do hope that people are comfortable sharing experiences and we're able to kind of have a conversation after I kind of done presenting a little bit of information that I was able to find. And I'm going to talk a little bit about my own experiences and some of my thoughts as well. So I want to start by just talking about how do we currently understand the prevalence of symptomatology within females and female carriers. And so when we look at the literature, it's about 8% of women who have carrier status or sort of involvement, whether it's symptomatic or asymptomatic, that it report sort of noticing more symptoms that we actually are able to capture on a clinical exam as well. So that really tells us, rare within rare, right? So it's hard to start to make sense of population data when you have a small population. So one of the things that we really need is more awareness, right, of what is going on in our community and where do we need to start focusing and being helpful. I mean, the bigger concern, though, outside of muscle involvement, skeletal muscle, is cardiomyopathy. And we do see a fair amount of cardiomyopathy, especially as women tend to age, although we can see that in younger females as well. And so about 40 to 50% of women who are carriers are going to develop some form of cardiomyopathy. And that does seem to kind of get worse with age, which makes sense from a neuromuscular standpoint, but also just from a general human and aging standpoint. But there's a lot of diagnostic challenges, as you all know. One, historically, you can't study something that we're not considering as real or we're not looking for. And so there's a lot, I think, for a long time of invalidation of women's experiences of what they're noticing in their own bodies. That didn't correspond to some of the current measures and the ways that we evaluate this in our boys. And so, for example, like CKs tend to be high in females, or they can be high in females, relatively high even sometimes, but there's not necessarily a correspondence to muscle weakness that we see in males. And so it's not like necessarily the most helpful lab as it is in the boys and the men, but it's an important lab nonetheless. The tricky part is that it kind of creates some confusion because we don't see the muscle phenotype progression in women as we see in our boys. The other thing that's really challenging is there's a decent proportion of females that have been identified as being carriers of DMD and having some symptomatology that don't actually have a family history of males in their family having DMD. So we have a lot of women who have kids with DMD that are falling through the cracks, but then we have a lot of women who don't have any idea that this is running in their family or something to be considering or looking for. And it's super rare. And you guys are in this community and have a hard time getting doctors and other people to take that seriously, to listen or to validate that historically. And so I can imagine just even the diagnostic journey that some of those women are on, or not, because they're just kind of told there's nothing wrong with them, but there might actually be something that is identifiable that can account for some of the experiences they notice throughout their life. There's a really vast symptom pattern variability. So unlike the boys and women, what tends to look like is a lot more asymmetry in how muscle weakness sort of presents. And so unlike the boys who tend to lose, muscle down up from the feet up, or not lose muscle, but lose function, women can have a much more asymmetrical pattern. They might have weakness maybe in their upper arms, but not their legs. They might have weakness in one arm, but not the other. They might have weakness proximally, but not centrally. And so it becomes really challenging to start to make sense of something that looks really different across the entire spectrum, unlike the boys who tend to have a more consistent or predictable phenotype. The age of onset is also very variable. So we see reports young in that early childhood sort of range, 7, 8, all the way into midlife, and past that. And so that's the other challenge, right? Is that as symptoms onset is different, that makes it hard to also understand trajectories, make sense of experiences, and sort of start to characterize a phenotype within women that we can use to have better diagnostic processes and recognition of what resources or what additional interventions might be most helpful. But the physical symptoms are really can be incredibly problematic, but not one, just because of how they affect you as a human, but two, because they're not necessarily appreciated within the medical community to the degree that is affecting you all as humans. So as I'm sure you all know, the most common symptoms first noticed are muscle sort of weakness or sort of exercise intolerance, getting fatigued quicker, having a lot more pain or discomfort when we're really active. And in addition to that, we see sort of a limb girdle type of weakness pattern, abnormal gaits, sort of enlarged calves, and scoliosis. And the scoliosis one is something that is really kind of common and important. We're going to talk a little bit about this in a minute. But that is also something that can evolve with age. And then we also just see that general sort of muscle pain, discomfort, and cramps. And so these can all have big impacts, right? And if you're going to the doctor and they're not sort of appreciating the genetic underlying factors here, they don't know to look for them, and you're having a lot of issues, your kids are, your daughters are, it can be really hard to make sense of that. And we can unintentionally do a lot of things that invalidate and make kids in particular sort of incorporate that into how they see themselves as humans. We also see higher fat fractions in women, even those that are asymptomatic. And so even women who maybe aren't noticing or don't have a level of impact that is challenging on a day-to-day basis, there is still underlying things occurring within the body that we do need to be studying and making sense of, and it will be helpful to other women and other boys and men. And so even our asymptomatic women need to have some sort of medical following and involvement in making sure that their care is as well as managed, and making sure that those caring for them know of their genetic history. And all of these kind of things put together, in addition to some things I'm about to talk about, make this, the clinical severity is such a broader spectrum for women. We can see a very Duchenne-like presentation, a more of a Becker-like presentation. And unlike we see with our boys and men, the prognostic ability to say, okay, you are carrying a genetic change here, we can predict that your functioning will likely look like this. We just can't do that in women because of the complexities associated with that. particularly because the patterns of dystrophin expression within women are much more variable than boys. So the models that we have and the models we're using to understand dystrophin expression in males are likely not the most appropriate for understanding that in women. And one of the thoughts behind that is that women are a little bit protected from the wild type allele that is producing some dystrophin. So there's some thoughts that there's this like sort of protective factor, and we really don't know how those are interacting within the body as well. Additionally, when in the small literature base available, when people actually look at functioning in women and look at how their muscles impact how they can do things, there's a lot more compensatory movements involved in women, which means, so let's say some women maybe have certain muscles affected, but not all muscles, right? So the other muscles that are not affected are compensating. We're using different movements, we're engaging different muscles that kind of offset the weakness that we would otherwise experience. And that makes it super challenging to diagnose and understand muscle weakness and the impact that might be happening, particularly when, from a clinical standpoint, the weakness is minimized because of the compensatory ability of the other muscles. That does impact performance. So there's in this one particular study, looking at the impact on performance, it wasn't uncommon for there to be a longer time needed to complete a task. However, that is not directly related to the proportion of muscle compensation. So people that completed a task faster didn't have a less affected, proportion or a more compensatory movement profile than those who didn't. And so some of the tasks that we have, like a 6-minute walk, that lets us look at how quick can you do that, and that gives us some indication of your, where you're at in a neuromuscular functioning standpoint, wouldn't be appropriate probably for women, because those are not related. So we can have much more affected times, and have not necessarily a great compensatory movement profile along with that. And so our dystrophin expression, our CKs, and our outcome measures right now are just really not appropriate for really understanding and capturing how do we understand the impact for our females. So we have to go off of what people report, which is hard because for many, 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 many years until more recently, that wasn't something that most people were kind of attending to as significant information of concern. But there's real impacts of these things physically. And as we know, emotional, behavioral, cognitive, and physical health are just really interconnected. There's that asymmetry of muscle weakness is not only very common, but it really tends to impact posturing. So that scoliosis sort of thing. This results in other downstream effects like chronic pain, challenges with seating, performance in workplace types of things. And additionally, I'm not even going to try to make sense of this, honestly, so I just put it in quotes. But the important part is, even though we're maybe not always seeing it, there is some real data to really suggest that there are some unique underlying factors from how maybe female carriers have fibrotic remodeling and some other things that we know are involved in our boys and men because of all the research we have there, that maybe looks a little different, but that is something that is really important and maybe a factor of diagnostic significance down the road. Indirectly, there's a lot of other factors as well that exacerbate the physical impact for women, right? So a lot of physical caregiving demands when you are a caregiver, and if you have muscle weakness and there's a higher demand load on you from a function of like needing to lift and needing to do more physicality type of things on a day-to-day basis to help care for your kids. Puberty. Puberty is a hell of a drug, and we don't know much about how that impacts our boys and men, and we certainly don't know how that impacts our female carriers. Likewise, menopause, and also pregnancy, the delivery process, and just understanding the impact of sports and strenuous activity as we do in the boys and we do in regards to how does that impact muscle weakness and fat infiltration and fibrosis and all of the things. Additionally, there's a lot of reported concerns related to learning disabilities and just general behavior problems. And even for those women who are not diagnosed formally with a learning disability or a mental or behavioral diagnosis, about 20 to 25% of adults historically, right, will say, yes, I was always worried that I had a deficit in this particular learning or cognitive area. So that tells us, right, like we have a lot of females likely kind of falling through those cracks and not necessarily kind of being caught or appreciated early and in a way that is maybe helping them be as academically successful as they otherwise would be. And when we look at actual neuropsychology data, the areas that tend to be most impacted are are very similar to the boys. It's actually it's very consistent, maybe to less degree, but consistent. So these are things like attention and working memory and executive functions, which are, frontal lobe. We know that there's delays there with our boys. Working memory and immediate verbal memory, also very common in our boys. And visuospatial skills, which is commonly impacted in our boys, but there tends to be a bit of more of a spread in visuospatial skills. So perhaps the physicality type pieces of how do we understand Duchenne and Becker in our boys are not the best, right? The measures CK and our current functional outcome measures, but the neuro and cognitive underlying factors and the symptoms and the things we see there might actually be of diagnostic and clinical utility in helping women sort of get that foot in the door to get the needed care, medical care they have, as well as the emotional, mental, and academic sort of resource remediation that might be most appropriate for the role that or the way that dystrophin is potentially impacting the female brain. And really the big, as a psychologist, one of my biggest worries always, for anybody that is experiencing challenges with regards to their neural development is that there's, downstream or secondary consequences to that. In particular, having cognitive learning deficits that go unnoticed and unassessed and unsort of supported, not only impacts socialization, but it also impacts your risk for sort of developing secondary mental health issues related to your experiences navigating the school setting and your peer groups in that space. So when we look at the actual mental and emotional and cognitive impacts on women, the first part is that there's just not a lot of data out there that on that. We are working on it. We have a study we're gathering here in my institution, and I know there's some other researchers that are working on that. But this is going to be very anecdotal because I just don't have that literature. But so the in my experiences in working with moms and talking with a lot of moms over time, anxiety is really common. And I have not met a carrier mom. Maybe I've met one, but I'm sure there's one out there. I have not met many carrier moms or that don't endorse some sort of history of anxiety. It might not be super severe, but it's definitely something that they self-identify and feel that they have experienced in some form of capacity throughout life. Mood-related concerns are also relatively high. One, just because, again, your physical and emotional functioning are really, really, really related. And so not only from all the care demands, same with anxiety, not only all the care demands associated with being a mom, but also a mom of a child with special health needs. But when your physical functioning is not tip top, right? You're more fatigued, let's say, or your muscles are weaker, or you have some form of cardiomyopathy, or these things that impacts how your body functions and feels, and that is going to directly also impact your mood. And so we have psychosocial factors contributing to mood and anxiety, but then we have physiological and physical factors that are also going to exacerbate the impact of those psychosocial factors. We also see higher rates of attention deficit and hyperactivity disorder in our carrier moms, or those reported as being diagnosed with that, and having some form of treatment, whether that be medication therapy or psychotherapy. And then again, those specific and generalized learning difficulties, less diagnosed, but much more sort of informally reported, or sort of like, oh yeah, I've always struggled with math, or I had a harder time with reading, or it was hard for me to pay attention, and so I needed more time, or XYZ. And so really trying to better capture that in our littler females as well as our adult females is really, really important, because that the psychiatric and neurocognitive learning profiles might be our best indication for females, when they're younger, getting referred for some of those things that might say like, oh, we should actually work these other things up medically as well, because that constellation of symptoms might actually indicate an underlying genetic disorder that we would have never otherwise considered or looked for. When your physical and mental health is uh, not in a place that is maybe best for you, anybody is at higher risk for substance use and misuse and abuse, as well as dysfunctional sleep. And those two things kind of exacerbate all these things in and of themselves. And the sleep issue is definitely very prominent and prevalent in our community. The substance misuse and abuse, I honestly don't know how prevalent that is in our community. What I do know though is that we are at higher risk of engaging in those types of behaviors when we are having more experiences of mental health dysfunction as well as physical dysfunction, particularly those that kind of contribute to reducing mood, like feeling fatigue, feeling tired, having more pain, having difficulty sleep or getting comfortable, some of those things. Additionally, I think that I have concerns from my work with moms and my work with boys and moms, that they have a similar sort of poor heart rate variability to the guys, or in the sense of their stress response. And what we know about that is something that has big implications for just overall health in general, but also for emotional and mental health. Um, so I think one of the areas that is definitely in need of further explanation or exploration is how do we start to look at the stress response of females, and is that also a proxy for helping us diagnose or better understand or better appreciate some of the muscle involvement in symptoms that people experience that are hard for us to capture on the current outcome measures that we have. And just a reminder, heart rate variability is a measure of our stress response system. So we want high heart rate variability in the sense that when our bodies are very stressed, our heart rates are going up, and when we're really relaxed, our heart rates are lower. So we have a big variability in our heart rate sort of reaction. When we have poor heart rate variability, we have less difference in how our heart is responding when we're stressed and when we're not stressed, which tells us that those environments are maybe not differently experienced by our body, or we're not acclimating or adjusting as we should from a parasympathetic standpoint. And so our body is perceiving even calm, neutral environments as stressful, which is not ideal because we very much want our body in a rest state more than a stress state. There's also the intersection of being a carrier and caring for a child with DBMD. One, just because that is hard in life, but it's hard on your body as well. And then there's the sort of larger conceptual piece, similar to the guys, that just is the underlying impact of the intersectionality sort of around having potentially something that impacts your muscles and in a way that maybe causes some barriers to preferred leisure activities and other things that we would like to do. And over time, I think similar to some of the boys and men, the females that I've talked to or worked with, whether they're adults or younger, it can be hard because similar to the guys, there's a lot of frustration and internalization and trying to make sense of like, why is my body not doing what I want it to do? Like, why am I slower than other people? Or why can't I keep up? Or why am I not as good at sports? Or, these other places where a lot of pure sort of socialization and connection and things happen. So if we're limited in that, or we're, self-selecting out because those aren't feel good, we might have less exposure to certain things that are important or would be important to us, less opportunities to develop our leisure interest and form social connections that are meaningful and that sort of partner with our values as humans. And so there could be that disconnect, and that's something that carries over time, right? Because those are the early life experiences engaged at school and with our peers and being able to do things we like to do really shape how we see ourselves and how we feel about ourselves and how we see ourselves in relation to other people in the world. And so I think thinking about and starting to have conversations around like our younger females, I think is really important, because we really are, I don't think, doing anything, much of anything, if anything at all, around talking about that experience for them and helping them figure out like how to make sense of that and how do I do this in the context of like developing my sense of self and developing a concept of who I am and what do I like to do. Um, we don't know again much about dystrophin manifestation in females, or sorry, DBMD manifestation in females. So I'm going to extrapolate from the boys, and these are slides I'm sure many of you have seen several times. But exposure is always helpful when we're talking about things that are very conceptual at this time. So we don't, so like I said, we don't know in women how certain things play out, but what we do know from our boys and our mice is that there is a real involvement of dystrophin in the brain. And this is important because I think in ways that we, we see women compensate muscularly, we don't have that in the brain, right? So I think we're seeing a little bit more pure manifestation of some of the impacts from a neurocognitive and neurobehavioral standpoint than we would see in our from our muscles. And so I do think the brain is going to be a really important part for helping women sort of advocate for understanding this disease context within within female gender solely. So not only do we see dystrophin in the brain, particularly related to excitatory processes, DB71, but inhibitory processes like involved with DP427, and then also in the fetal developing brain. So just as we talk common about the men or boys having sort of this neurodevelopmental overlay, so neuromuscular disease, it's also a neurodevelopmental disease. I think that could apply to women as well. So because we have a neurodevelopmental risk doesn't mean that will come to fruition, but understanding that there might be real things occurring prenatally and in fetal development and as our brains are scaffolding, that does change how our brains are compared to other women, I think is really, really important when we comes to understanding how are some of the things being reported or that we're collecting, is there consistency or constellations of some of these things that we might be able to start to use to really refine resources and interventions for our younger kiddos in particular. Additionally, when we look at our MDX mice, we know that they have a lot of dysfunctional fear arousal, and that is increased as we get more dystrophin proteins sort of eliminated from the brain. And so we see a more severe heightened anxiety response in mice in response to very neutral or sort of even positive threats at times. And similar to our boys, there's, I think we have a reason to say we can't, I don't know why we would see maybe different patterns of dystrophin expressed. So we should assume until we know otherwise that we would have more of an amygdala implication for our women as well, and a similar fear response profile, which makes sense when you kind of look at the sampling of women and what they report their mental health sort of histories as, which is why I think we see majority of like anxiety, ADHD, some of those mood concerns over more of those autism-like in some of those more extreme behavioral presentations than the guys. They're not as affected, right? But I think the ways they're affected they play out in more of a normative anxiety versus such a heightened anxiety for the guys. And when we looks at actually stress response to that heart rate variability and just physiological arousal patterns, if you're not a carrier and you're not somebody that has DMD, your pattern of arousal is going to look something kind of like this over the span of a day. So this box is really telling us this is like our distress tolerance window, and everybody has a window every day, and our windows change. So if you've got good sleep and you're healthy and you're living in a good environment and you're not having a lot of pain and you're eating well, your box will be bigger. And if you're stressed or there's a lot going on or you're not doing well, your box might be smaller. So there are times you tolerate stress better than others, and these might be, if you've ever noticed, something happens at work that's really stressful and you normally can handle that, but then there's a lot going on and you're not handling it as well, and you might go home and like snap at your partner, and you wouldn't normally do that, right? You're out of your window, right? So it's not that that's who you are, but we all have different tolerance levels, and our tolerance levels change. So this is a pattern here in the middle. You wouldn't notice this. Our body's doing what it needed to do, right? So we have our sympathetic, our activating fight or flight system, and our parasympathetic or our hypoarousal, like kind of like shutdown system. And your body does this naturally when you're doing anything, right? You're getting moving, your body's activating. It's like, cool, we're thinking. It's a good stress. So we're, releasing those hormones that we need to get our body ready, prepared to learn and to prepared to do. And then, when you transition into something where you're not as active, your body goes more into a state of rest and digest. And that happens unconsciously. This is a system that just kind of it really works. It really manages itself really well in a homeostasis most of the time. I walk to work often. If I'm walking to work and I almost get hit by a car, I'm going to notice that. I'm not an anxious person at baseline, but I'm a hyperactive person, and I have a lot of energy. I'm a reactive person. So I'm going to have a big swing probably in my body. I'm going to be like, "Whoa," and I might notice shifts with that, right? Like I might notice my thoughts change, and I was happy and singing, and now I'm like mad, and like, hey, watch it. Or I maybe notice my heart rate goes up, or I feel hot, things like that. I'm going to shut down quick, right? Because I am not somebody that's, again, super anxious. But if you are somebody with anxiety, and this is what a lot of my carrier moms will report, is that green line can actually, it gets extended out, and it doesn't shut down as fast. And so the more your body is anxious, or your body stays in a heightened sort of sympathetic state, the more your body learns to hold that, right? It's like, oh, okay, we're doing this, right? And so the more that you have those experiences, the harder it is actually to get back down to baseline. Your body kind of stays up there, stays heightened. And when I look at these patterns in our boys, I see a pattern that looks like this. And so this is very brain driven up, right? This is the dystrophin, and how the brain is being impacted from like a excitatory standpoint. And you can see that they try to shut down, and they kind of kick back up, and that's muscle, right? And we see that even in our younger boys who are doing great from a pulmonary standpoint and a cardiac standpoint, but just have enough sort of diffuse muscle weakness that they maybe have a little bit more of a chest style pattern of breathing. They're maybe not it, relying as much on their diaphragm to like do big deep breaths, or it might be really hard for them, honestly. And so that I feel like that's kind of the muscle. So it's that intersection that kind of kicks them back up. That is a less of a reality in our women because of having better muscular functioning, less weakness. So we don't see that the intensity of this as much, I don't think. However, we do see a similar pattern. um and the interesting part is in biological child mother dyads and fathers, to be honest, there's such a relationship physiologically between them that it can be hard for boys and moms to regulate when moms are symptomatic carriers. And what I mean by that is um, when a child is dysregulated or escalating, it's hard for the mom not to, even if they're trying really hard or faking it till they make it, right? And they might not be bothering here, but this is just body reaction. And so they kind of can like kick each other up. And if we kind of take mom out of it and just, put dad in and put the kiddo in dad's lap and just be like, don't even think about stuff, just relax, you'll see kids map on to dads and kind of shut down. And so at times, unfortunately, just because of how biology is and how socially contagious we are as humans, there are real interactional effects for moms and kids, I think, that kind of exacerbate both sort of stress responses and just how the body is functioning. And that's often like without even any your awareness, right? It's just these things happen so quickly throughout the day, and that can have a huge impact over time on just your health and how your body feels. You'll be like, I have no idea like why I feel so exhausted today. And your kiddo might have been super anxious, and that might not have been playing out in a way that you were affected, where you're like, oh my gosh, we've been dealing with this anxiety and these meltdowns all day. But like you might notice it physiologically, unconsciously, and feel that. And that is going to impact your behavior, later in the day or whenever. So I think these physiologically pieces, heart rate, stress response, looking at the patterns that aren't just our outcome measures are really important. And not only how we understand our kids, but how do we understand ourselves and ourselves in relation to our kids as just biological beings. The other additional factors I feel are important, and I talked about a bit, are just really, there are real differences in biology between biologically born males and females, hormone expression, puberty onset. And we just don't know a lot about how those secondary things impact internally, like dystrophin expression and muscle functioning and all sorts of things. And so one of the papers I found when I was putting this together was really interesting. It just looked at like estrogen and other hormones in MDX mice. And in their study, there wasn't an impact really on estrogen on skeletal muscle functioning by any means. However, it did seem like there might be reason to continue to explore estrogen expression in relation to like how female muscle recovery happens after an injury. And so I think as we get further into exploring and doing better science around these things, we might kind of be looking at some of those other very female only specific factors that might help us better understand why we might see certain behavior or muscle phenotypes in women compared to boys, and why there might be such a variable spread. While we're doing a lot better at cardiac monitoring in women, we really are not doing a ton of research, and we're certainly not doing research in relation to pregnancy and how that impacts heart and stress response function and cardiomyopathy in general. We know that pregnancy is a lot in the female body, and we know that pregnancy outside of just DMD and BMD, DBMD, like can impact cardiac functioning in general. And so I think there's a lot of reasons to be thinking about like the specific things that women kind of go through in life, and how that might actually play in relation to having an underlying genetic condition or being a carrier of a genetic condition. And then for our younger girls, you know, how do we look at puberty and the onset of puberty? We don't know much about our guys, but there does seem to be some rescaffolding. I mean, any kid going through puberty, there's rescaffolding of the frontal lobe. And I think there's some talk and some data that suggests like that might be a little bit different, or it might look different or be experienced different by our boys. And so things like that, I think, are important for us to start to consider. The pattern of neuromuscular weakness and muscle involvement and the psychosocial impact, and ways to talk about that and help females navigate their social community and make sense of how do they talk about, you know, their experiences and navigate that so that they're not have limited or less exposure opportunity in those spaces that are really important for developing ourselves as individual humans with our own hopes and dreams and wants and fears and things that help us, you know, feel connected and included with other people. And I think we have real concern. I think this is the area that I see probably the most consistency in our females, is that neurocognitive and neurobehavioral sort of phenotype. And so really understanding the impact from a learning standpoint and from a mental health standpoint around experiences of anxiety and treatments that go into that. Because the ways that we treat our guys are a little bit different than what you would maybe do all the time for other kids without dystrophy. And I would imagine a similar approach to understanding mechanism of actions for medications and therapeutic interventions, like psychotherapeutic interventions, is probably going to be just as important as it is for the boys, in order to have the most effectiveness from those things that we're doing to be helpful as we possibly can. Thank you. Got some references, and I think now we will chat and learn from each other, hopefully, or mostly me learning from you.
This is so good. Like, I don't even think you realize how impactful this was. Like, we have so much in the chat. You know, people are like visual spatial skills, weak posture. Like it's been very validating for some of these people. Mindy, I see you have your hand raised. If you have a question, please do put it in the Q&A box. But again, thank you so much for doing this. We do have one question that came through, and if anybody does have any other questions, please feel free to put them in here. You can also put it in the chat if that's easier for you, especially at this point, since we are looking at that specifically. But the question is, what does this mean for our daughters, which I think you touched on, but they're concerned about learning disabilities for their daughter, and she's going to start school soon. Can we push for genetic testing in-house? So I'll let you weigh in, but from my seat, if if you feel like there may be an issue, I would connect with PPMD on genetic testing, connect with your physician. I would reach out to Trina Stelly. She's our resource specialist who has a focus on the female population, Trina at jetfoundation.org, and she'd be happy to guide you. If you are a carrier, I would recommend getting your daughter tested as well, but that is a family choice. Dr. Truba, what are your thoughts?
On which part specifically?
So learning disabilities in school, and then also, do you have any recommendations for genetic testing as well?
Um, I think if there are any, like even small concerns, like if you have a daughter that's starting school or you're noticing at home, like, oh, they just take a little bit longer, or we're noticing, and I think where a lot of girls fall through is like they might be like right at that cusp, right? Like, oh, there's like they're right almost there in the normative, right? So it's super close, so we're not overly worried about it, right? I would say if there's a family history known, definitely I would pull the trigger immediately on like a neuropsych eval, get ahead of that and make sure there's not maybe underlying factors that are going on. But again, females are also very good at compensating neurologically better than men. And so they have probably a lot of compensatory things that offset some of those deficits in ways that maybe some of the boys don't have. And so I think really like a good eval around like where are your strengths and weaknesses is really, really important, and really pushing for those things to be remediated, because we don't know. And if we don't know, we should assume, yeah, their brains are impacted and this is happening, right? Because we don't want to miss the window to trying to get resources and interventions in. Um, the genetic testing question is a challenge because, as Alexis said, it is, a family-based decision. There are pros and cons, right, to genetic testing prior to 18. I think if we're worried that we're having some symptomology, I think genetic testing would is really very valuable there. One, because if we don't have that information, we won't have enough data to start to extrapolate and make sense of and start to actually put together more sort of clinical research studies on females and sort of what might be helpful. Um, or if you're recommended for neuropsych eval, or if there's concerns, I would say, and there's a family history, that would be another good reason to kind of pursue genetic testing. And if you don't, I think still operating like, okay, let's assume and approach as if a female carrier from a learning cognition standpoint, and making sure that we're remediating any academic things, especially if we're not seeing more of that muscle involvement or impact on a daily basis for the muscles. Because again, if we don't know the scope of the problem and the ways that females, are manifesting symptoms, and we're going to stay in the dark. And so until we have that data, we're going to continue to be in the dark, or we'll know a lot about females, adults. But as you guys know, I mean, when we try to go back and apply that to peds, it's not always the most appropriate model, because children are not just little adults. They have differences in their biology and all sorts of things, and how their bodies function. And so I really do think we need that data from our girls.
And I think this question kind of piggybacks on that, is how do you have that conversation with the younger girls in terms of genetic testing? Because we always hear wait till they're 18 to let them choose for themselves. But to this person's point, with the potential of cardiac issues, families are choosing to get them tested earlier. So how would you have that conversation with your younger child?
That's a tough one to answer. It probably depends on like your kid's age and their developmental sort of level, and like who your kid is. Um, I am a big fan of honesty, and so I think developmental scaffolding and having a conversation that maybe is scaffolded over time to help promote understanding would be a good approach if possible. Um, I think helping kids understand genetics and like what they are, and why testing makes sense or doesn't make sense, or what the benefits of that would be, um, is always helpful depending on age. Like making sure your daughters are involved in making that decision, and kind of sharing what their risks are, what they would like to know, or if they think it'd be helpful. Um, but yeah, so that's hard to answer broadly because it probably each kid needs it kind of tailored in a different way. So I guess I would encourage sort of talking with your genetic counselors in your clinics or through any of like Jett or PPMD around some of those like genetic counselors or parent patient advocates around um, maybe some strategies for framing information could be helpful. Um, I think a lot of kids, especially if they know it's something that would help them, it would help other people. It helps them, know more about their body in a way that tells us a lot, and that you can always tell them too, like it's something that we can do to help us as your parents, right? Like know what to do to help you the best and make sure that you have everything possible. And if you want to know, great. And if you don't want to know, we don't have to tell you, right? Like it's one of those things that we can use to inform information. And when you're older and ready, we can talk about what that means, right? And in relation to the care decisions we've made to help you be healthy. And so I think there's a lot of different ways to do that depending on your family and your kid.
Perfect. We don't have a question, but just something, in terms of the discussion. So I've noticed a big change in muscle recovery as I've aged. I thought it might be the muscles are becoming affected by dystrophin deficits, but maybe it is about postmenopausal changes in estrogen. Not really a question, but interesting. So just to your point and part of your presentation, just to add to that piece, if especially if anybody else is experiencing that. We do have a question. Um, how do we treat issues such as, you know, how do we treat behavioral issues in this population? Is it any different than the general population? Medications, modifications, etc.
Um, I honestly don't know. My knee jerk, like my if I were to hedge a bet, I would say yes, based on what we know about the boys and what we know about the boys and their brains. I think we see more similarities in brain and in neurobehavioral and neural learning than we do in muscles. So I would anticipate that we might have more similarities in how things maybe impact the brain from a mechanism of action from a medication standpoint. And then with regards to modifying treatments, I would say probably in with regards to some things that maybe would be very effective for some people might be less effective or be different if you are a symptomatic carrier, manifesting carrier, and do have more muscle weakness or cardiomyopathy or other things like that that can impact sort of how your body responds to stress, but how it can calm and relax using sort of behavioral strategies. Like we have to modify a lot of that for the boys as well. I don't think it would need to be modified to the same degree, but again, I honestly have no idea because I have not done enough with enough women to be like, oh, there's some similarities across these things. But but my guess would be yes. And I always tell the moms that I see in clinic who ask about medications or other things, like my recommendation would be to start if we've never been on them or anything like that and we're looking, I'd be like, I would start with the medications we know tend to be the best and most tolerated and most effective with our guys.
Right. Absolutely. And then should adults who are carriers get tested for ADHD and ASD?
I think if you have symptoms, I think it could be helpful, especially I think, it's hard to diagnose. ADHD and autism are underdiagnosed to women anyway, because women have more socially compensatory behaviors and better language development than guys at an early age. And so they can kind of fly under the radar. And so I think if there's concerns or there's worries or you're like, yeah, I've always thought this about myself, I would say yes, because again, if we don't have that data, we don't know, right? So right now you know, I see in the chat like, oh, I have anxiety, I have ADHD, or I'm diagnosed with OCD, and I feel, and like I hear that a lot, and so I think it's out there. I think if we were start to capture it, that would better provide guidance to people doing testing as well and helping them understand maybe the implications, because sometimes in these assessments there might be a deficit, but all these other compensatory things kind of offset that. So it's like, yeah, but like you're kind of okay because you're like doing these other you have these other things sort of to figure it out. But what we need to know is like, what is that deficit, right? Because that might actually be really important for actually like tailoring other sort of supports and like recommendations for earlier for our girls, like we do for our guys. So we know with their neural profiles, like we recommend testing very early, and tapping into things like speech and language therapy and other things to sort of remediate that before we get too far behind. And I think something similar would be identifiable if we had enough information from where either in the brain, like where do we see those more of those deficits sort of manifest in what areas or sort of control responsibility processes, and as well as sort of just like academic performance. So we have, two measures. We're like, how do you do in school? How do you apply? And like, how capable is your brain of learning? Right. And so those are two different things. And I think that's important because we might have sort of deficits in compensatory behaviors, but that might not necessarily play out academically as we would expect. And that would be important for us to know as well, because that would be a little bit different from the guys because there's a little more consistency in that for them.
Perfect. And then this is a question that I've seen multiple times, so but I think this sums it up pretty well, and I'll add my 2 cents after yours. But how do we as a community push for more knowledge and awareness for females, both pediatric and adults? How do we convince clinicians and researchers that this is a real thing and to get and record data?
I think things like this are really important. I think bringing women together and starting to share experiences and see the similarities. It feels like very similar to when I started in this community 7, 8 years ago and was just hearing so much about the behavior, but we weren't really talking about it yet. But so many parents were just saying the same things. And I have that experience with women, especially like I see at conferences and like, oh, this is like kind of what I'm experiencing or noticing. I do think there's a lot more similarities than we appreciate. And I think the more that we get people together and we're like, yeah, like that's how it is for me, it is for me. And people are hearing that and we're being loud and we're demanding. I don't know if it's I think the problem is that like we shouldn't have to convince providers if you have a bazillion people in a community and or so many people in a community saying, "Oh, I experienced this." It's probably real, right? And so I don't know if I really hope it's not doesn't feel like a convincing anymore at this point, especially over the last couple years. And if it does, then I would say like reach out to Jett and PPMD and Cure Duchenne and all those big names and say like we need to start like demanding care centers are involving this, and we need what's up what about my daughter, like what about my daughter, what about my daughter, what about me, what about my daughter, what about me, um, and like demanding some of those care. And if not, say like, well, who do you recommend I go to? Because I'm noticing these things and, I want to make sure that, my health is good, because then if we're capturing it again, we can study it. But we have to capture it and we have to get that, natural history data. We got to start somewhere.
Yeah, and I think in general, like you said, like there are unfortunately still stories that are here where we're having to convince providers that, this is a real thing. But I think that, you know, advocacy organizations like us and PPMD and others are part of that conversation now. And we all know that it's a real thing. So we are all doing what we can to help educate the community and educate physicians that may not be educated. So I think that's something that happens on an advocacy level as well. But like Dr. Truba said, also advocating for yourself and leaning on others. Like you see so many women in this chat who have experienced these things and are carriers and are newly diagnosed carriers. So leaning on each other. We do have a carrier conversations group that Trina runs as well, where we talk about these things. We talk about, what to do, where to go. We have a list on our website of providers that I'm sure it's not an extensive list, so it's not full, but we are trying to continue to gather information on providers that do treat carriers, both adult and pediatric, and have knowledge in it and are willing to treat it. So, it is something that we're actively, as a community, I think, understanding more about, which is, like she said, this is something that behavior is not well understood, but we're learning more about. And I think the community as a whole is something that we're learning more about as well.
Yeah, and I agree with Cheryl. I think educating the payers so that things are covered is incredibly important. A lot of advocacy and um, educating providers obviously sounds like it's really important. But I think at the end of the day, like stepping back, and we can't speak out of both sides of our mouth as clinical researchers anymore. We can't be like, okay, like, moms are super important and you guys are taking care of these kids and, there's real demand and like, how's your mental health? And like, how is this going? How's this going? And then be like, we're going to not really take seriously the physical implications, because those are really important, because who's going to take care of your kids if you're super affected by these things over time? And we're doing a lot to help people live a really long time. And so this is going to become a much bigger issue for our population than I think we've known, because our survival rates are increasing, which means we're going to be caring for much later into life when these symptoms, I think, are much more noticeable or maybe prevalent. And so I think we're going to come to a precipice for, in the coming years, coming decade, where we see more of like these concerns playing out, the consequences of not doing anything yet, and not, being in a place that those things have been targeted as just as important as developing gene therapies and working on improving pulmonary functioning and cardiac functioning in our boys. I think that's where to be very demanding in a lot of ways as well.
Awesome. Well, I don't see any other questions, but again, Dr. Truba, thank you so much for your time. Everybody, thank you so much for being a part of this webinar. I think spreading the word and spreading awareness and learning more is just so crucial to not only this topic, but in general. If you do have anybody that you wanted to share this with, please do. It is on Facebook if you want to share it there, but we will have it recorded and we'll send the recording to all of you, including those that were not able to be on but were registered. If you do have any questions, please reach out to myself, Alexa at jetfoundation.org, and I will get them to Dr. Truba and she will answer them the best she can. And also I would connect you or encourage you to connect with Trina Stelly as well. If you have any issues or questions, she will definitely help guide you in the right direction. So thank you again.
Alexa.
Yeah.
Okay. I think the other thing is like just really sharing your stories as moms. I think and inviting other people. So one of the things I've learned, and I'm glad more moms are talking about it, but we have to remember if you're 40 and you've experienced symptoms for, 30 some years and you've been told you're fine and it's in your head, or you're just like not noticing, or people are like, oh, you just have a low pain tolerance, or you're like kind of lazy or whatever. You're not going to be like, let me share these things about myself that I feel really bad about and have like made me feel like less than. And so like, I think encouraging people to share and develop a new narrative around maybe how they've experienced this in the past will help kind of bring that in for our younger parents who are maybe newly diagnosed kids. And so we can kind of get a little bit more ahead of it than I think some of the weight that you all have carried of being told. I mean, I'm a psychologist. I get people sent to me all the time where, if we can't find a medical cause and a reason, we're like, well, maybe it's psychosocial, maybe it's psychosomatic, maybe it's stress. And sometimes that's true. Don't get me wrong. But oftentimes it's not. And it just is because we haven't found it. And I feel like a lot of women in our community have landed probably in that bucket for a very long period of time, because there aren't things that we're going to see medically, right? Because we're not looking genetically. And then they're not considering, that piece and maybe the ways that manifests and play out. Or we have, right, but we're like, oh, but your clinical data looks great, so like, like, nope, we don't consider that real for you. But that doesn't mean you don't have muscle pain, you don't get tired, and if you're told constantly like that's not real, right, eventually you're not going to keep sharing your story. And your other moms that that have kids who are older, like really being like, hey, like actually, guess what, all of that's real. And what Dr. So-and-so told you about, maybe it's just stress, like, because like, how hard is it to argue that as a parent of a kid with DMD? You're not gonna be like, well, I'm not stressed. That's not what this is. Like, hell yeah, you're stressed. Everybody's stressed.
Yeah.
But I don't think that until we really have a good sense of here, we can't go down that path. And so my biggest plug is, if there's one thing you take away is like, don't be like silenced or pushed into like the mental health space without like the workup around the genetic piece. If you're noticing these things and you have a kid with DMD, because there's real physical consequences to not understanding what's going on inside your body. That's not going to get picked up if we don't understand some of the genetic pieces.
Yeah, I think that's such a good point. And you hear that all the time of, oh, well, I definitely saw these things, but just thought it was related to XYZ. So that's a really good point, because I think this community is the one to definitely share it with. And that's the only way that you're going to get people to listen. So again, thank you guys so much for being here. We really appreciate you. Please feel free to share your story. And again, if you have any questions, please feel free to reach out. And again, thank you, Dr. Truba, and thank you to all of you, because we could not be here without you. Have a great day, everybody.
Thank you for having me. And I agree, Trina. That is a very good point. And let's
I
work on
feel
our.
like we need another webinar. We'll talk about it, but I feel like we need more. So maybe it's just a meeting where we just chat, but we'll chat soon and thank you all so much.
Bye, you guys.
Bye.